Hello and welcome to today's session. In today's assignment, we're looking at Alzheimer's disease. Alzheimer's disease is a disease that is currently affecting over 44 million population. It's a neurodegenerative chronic brain disease that is a type of dementia and is characterized by neurons failing to communicate and eventually dying, resulting in brain atrophy. So we have some interesting facts about Alzheimer's disease, like it is the fifth leading cause of death among adults aged 65 or older. And in 2021, more than 6.2 million Americans had this disease, but currently over 44 million are affected, and the exact cause is yet to be fully understood. There is that leading risk factor of developing this disease, and that's the rising age, and women are more affected and they are more likely to develop this disease compared to men. Black population is twice at risk of getting this disease compared to the white population. So this Alzheimer's disease is degenerative, it's irreversible, and it's progressive in nature and majorly affect the frontal lobe. If you look at the statistics, it accounts for about 60 to 80% of all cases of dementia. Remember, the other cause of dementia could be the Creutzfeldt-Jakob disease as the second cause. Alzheimer's disease normally progresses in stages. So we have the preclinical stage, the mild stage, moderate, and severe stage. This will be revisited when we be looking at the assessment. There is currently no cure or definitive treatment for this disease, but we have disease that can be used to improve the symptoms. In terms of pathophysiology, this disease initially involves parts of the brain that controls thought, memory, and language. So neurons involved in the communication, metabolism, and repair will be disrupted, with the two major neurotransmitters being implicated in this case. We have the acetylcholine and the glutamate, right? So in a case, we have these amyloid precursor proteins. These amyloid precursor proteins, they normally cross the cell membrane of neurons as usual and gets into the inside of the neuron. So we have enzymes which normally metabolizes these proteins into smaller components for removal from the neuron, and in the case of Alzheimer's disease, these enzymes they fail. So as a result, these beta amyloid proteins they start to congregate into the neurons, forming amyloid plaques. So the brain damage is actually orchestrated by these amyloid plaques, and the disease will show some distinguishing features of the brain tissue. First, we have the neurofibrillary tangles within the neurons, followed by the neuritic plaques that are found outside the neuron, and lastly, the granulovascular degeneration. Starting with the first one, the tissue changes in Alzheimer's disease, the neurofibrillary tangles. So these are bundles of filaments that are found inside neurons that abnormally twist around one another and ultimately cause neural death. Okay, so and they result from accumulation of abnormally phosphorylated tau proteins. Remember, in healthy brain, the tau proteins they normally provide structural support for the neurons, but in a patient with Alzheimer's disease, this structural support normally collapses. Right, so that explains how neurofibrillary tangles do accumulate and causing the damage. Second, we have now the neuritic plaques, and this one will be they will form outside the neurons in the adjacent brain tissue. So the plaques they contain a core of a beta amyloid protein that we had mentioned that's surrounded by abnormal nerve endings or the neurites. So we have overproduction or decreased metabolism of this amyloid peptide proteins, which leads to a toxic state causing degeneration of neural process, neuritic plaque formation, and eventually neural loss and clinical dementia. The third tissue change is the granulovascular degeneration, which occurs as these tangles and the plaques they cause neurons in the brain of the patient with Alzheimer's disease, and they cause it to shrink and eventually die. So first in the memory and language centers, and then finally throughout the entire brain. So this widespread neuron degeneration leaves gaps in the brain messaging network that may interfere with communication between cells, causing some of the symptoms of Alzheimer's disease. We have affected regions of the brain in Alzheimer's disease. We have the hippocampus, we have the the cortex, so the amygdala and the cerebral cortex. So hippocampus, it's responsible for learning new things and keeping the memory intact, while the cerebral cortex helps in understanding time, while the amygdala helps us in understanding emotion, memory. Remember that as more tangles and the plaques form, we have more loss of vital functions ability. The cerebral cortex, which is the outer layer of the cerebrum, is the one that is majorly affected. When you look at some of the components of the cerebral cortex, we have the frontal lobe, which is responsible for enabling us think, speak, and have intact memory and movement. Parietal lobe is concerned with the language and touch. The temporal lobe facilitates hearing, learning, and feelings. Occipital lobe works with vision, color perception. The brainstem is responsible for controlling breathing, heart rate, and temperature, and the cerebellum balance and coordination. We have some risk factors for developing Alzheimer's disease. Number one, we said was the rising age, especially the age over 65. So the risk of developing Alzheimer's disease increases significantly with age due to accumulation of brain changes such as these amyloid plaques and the tau tangles. Family history of Alzheimer's disease suggests a genetic predisposition, and this one increases the likelihood of developing this disease. Gene mutation, or we have these specific gene mutations, particularly the APO gene, especially the APO and the 4 allele. These are strongly linked to increased risk of Alzheimer's disease. Hypertension, for the high blood pressure, you find high blood pressure can damage blood vessels in the brain, and this will lead to reduced blood flow. And when there is a reduced blood flow, it means there is a likelihood of the inflammation coming in, and this will lead to cognitive decline. We also have conditions like dyslipidemia, characterized by abnormal levels of lipids in blood, which can contribute to atherosclerosis, cerebral disease, and conditions affecting blood flow to the brain, such as stroke, can also lead to brain damage and increase the risk of Alzheimer's disease. Atherosclerosis in the arteries can also reduce blood flow to the brain, promoting cognitive decline. While type 2 diabetes, the insulin resistance, we find that insulin resistance and high blood pressure, they can damage the blood, the brain cells and the blood vessels, and increasing the risk of Alzheimer's disease. Obesity, will result from high fat diet, and this will increase the formation of these pro-inflammatory chemokines. So, and these pro-inflammatory chemokines are likely to lead to inflammation and metabolic disturbances that will contribute to Alzheimer's disease. Traumatic brain damage and sedentary lifestyle, social isolation, low education, and risk, and also among other risk factors. So the blacks, you find the prevalence is about 14%, followed by the 12% for Hispanics, right? Level of education, the low level of education is a risk factor in that high levels of education are linked to cognitive reserve, which normally protects against Alzheimer's disease. For social engagement is beneficial for the brain health. Isolation can lead to cognitive decline, and this increases the risk of Alzheimer's disease. In terms of incidence, Alzheimer's disease is considered the most common cause of dementia in older patients, and approximately 14 million people globally are living with Alzheimer's disease. We have early onset of Alzheimer's, which occurs between ages 30 and 60, and we have late onset that will be occurring in the mid 60s. Gender, you find more females are more affected than males, and the probable reason is because females tends to live more and they spend more years on the globe compared to the males. The disease affects Black people more. They are twice at more risk compared to the whites. We have some complications where the patient could present with behavioral complications, metabolic complications, and other complications. Behavioral, the patient could be hostile, could demonstrate symptoms of agitation, wandering, and uncooperativeness. Metabolic complication, patient could present with infections, dehydration, drug toxicity, malnutrition, and aspiration. In assessment, we have the preclinical stage where there are no symptoms noted, but only pathologic changes found if tested. Mild stage, and this is the time where you need to plan for the future. Patient will be feeling that something is not right. This stage is insidious in onset, and we have initial changes almost imperceptible. So forgetfulness, subtle memory loss, misplacement of objects, inability to concentrate, personality changes, increased anxiety, poor judgment, taking long to complete daily tasks, and trouble handling money. That leads to moderate stage, and this is where you need to talk to the patients about the safety. Remember, this is the longest stage among the four. So there is difficult remembering past, there is disorientation, episodes of wandering and getting lost, and feeling of moodiness in social situations. Bladder and bowel changes, you have the patient demonstrates shorter attention span, misperceptions about own environment, and misidentification of objects and people, inability to recognize family and friends. There is decline in word finding, visual and spatial problems, and impaired reasoning and judgment. Patient could also present with difficulty in learning and remembering new information, and also personality changes such as being irritable, depressed, displaying paranoia, and being hostile. All right. We could also a patient could also be restless and demonstrate agitation, increasing in the late afternoon, the one that you might refer as the sundown effect. There's also a tendency to perform repetitive actions or statements and suspicion of fear and fear of imaginary people and situations. Complaints of stolen or misplaced objects could be seen, and we also have inappropriate actions or impulses such as undressing, motor problems, and also nocturnal awakening and sleep disturbances. If not managed well, we have the severe stage, and here the patient will need constant care. Okay, patients are going to present with self-care deficits. So we have general deterioration in personal hygiene, difficulty in swallowing, and this could predispose them to conditions like aspiration pneumonia. We have increased amount of time sleeping, so they may remain in bed for a longer time, and the weight loss because they have lost the sense of taste. So there is loss of also bowel and bladder control, and the patient may also grant. So, in terms of physical findings, we could, when looking at mild stage, there is impaired sense of smell, and there is loss of recent memory. We also have the moderate stage that is characterized by impaired stereognosia, where patient cannot be able to tell. For example, if you have a key in your pocket, you need to be able to to note that it's a key without necessarily looking at it. So in these patients, they lose that ability. You could also have gait disorders, tremors, confabulation, and delusions. In severe stage, Your assessment could reveal difficulty in communicating, patient with seizures, agnosia, that's inability to recognize and identify objects. Patient could also present with apraxia, this inability to perform purposeful movements or the gestures. Patient could also present with anhedonia, which is inability to experience pleasure activities from previously enjoyable moments. We also have aphasia, where patient could have a problem with understanding and creating speech. And lastly, we have anomia, where the patient can't recall names of objects. So we have some tests that we can do to rule out and diagnose Alzheimer's disease. Starting with the laboratory, we have vitamin B12 level test. You know, this test is performed just to check the levels of vitamin B12 in blood. Vitamin B12 deficiency has been associated with neurological symptoms, including cognitive impairment, which normally mimic the symptoms of Alzheimer's disease. So you carry out this test to rule out vitamin B12 deficiency as a cause for the cognitive impairment. Number two, we have the thyroid function testing. So thyroid function tests such as looking at the TSH, thyroid stimulating hormone, the triiodothyroidine and the thyroxine levels are conducted to assess thyroid gland function. So thyroid disorders, especially hyperthyroidism, this is underactive thyroid, can cause also symptoms such as memory problems and cognitive decline. So you can carry out this test to also rule out thyroid problems as a cause for the cognitive decline in your patient. You also have liver function tests, and this liver function test, it could include the AST, the LT, bilirubin levels. This one will be used to evaluate the health of the liver. So liver function tests can sometimes lead to liver dysfunction, can also lead to cognitive impairment. And this could be due to build-up of toxins in bloodstream that can affect brain function. So you carry out this liver test to rule it out. Currently, we also have blood tests being projected by the National Health Institution, and they are able to measure the beta amyloid proteins, which are the major problems in this Alzheimer's disease, right? So this is a welcomed move, and we hope it can really be a game changer in the diagnosis of Alzheimer's disease. For the imaging, we have the positron emission topography, which reveals metabolic activity of the cerebral cortex, and the computed tomography scanning, the CT scan, which shows excessive and progressive brain atrophy and rules out other neurological problems. For the MRI, it rules out intracranial lesions and detects biochemical and anatomical changes, including generalized and focal atrophy. We also have cerebral blood flow studies, which will reveal any abnormalities with blood flow to the brain and which could be contributing to the changes that we see in Alzheimer's patients. We also have the lumbar puncture, which can be able to rule out conditions, and the cerebral fluid analysis. This will show chronic neurological infections and possibly elevated tau levels and low amyloid protein levels. Electroencephalography may show slowing of brain waves in the late stages of the disease, or may identify another cause of dementia, such as the Creutzfeldt-Jakob disease. Biopsy remains the definitive cause of this disease, although this is done during autopsy. We have a criteria that we use to diagnose Alzheimer's disease. So the Alzheimer's Association and the National Institute of Aging have developed criteria for diagnosing Alzheimer's disease, as well as guidelines that focus on 3 specific stages. So we're looking at the preclinical, the mild cognitive impairment, and dementia. So in preclinical, there is evidence of measurable changes in brain markers years before any signs and symptoms involving memory, thinking, and behavior are noted. So this is being used primarily for research purposes and not for diagnosis. As for mild cognitive impairment, we have noticeable mild changes in memory and thinking that can be measured using a mental status examination, so changes not severe enough to affect daily functioning here. For dementia, we have significant impairment in memory and thinking and behavior impairments. So impairments severe enough to affect ability to function independently. So that's how we can categorize Alzheimer's disease. In terms of treatment, we can have the general. The general, we have behavioral intervention, so that is patient-centered or caregiver training focused on managing cognitive and behavioral changes. We could also have occupational therapy, music therapy, and advanced directive planning. For the diet, we require well balance that needs to be monitored. You avoid drugs like caffeine, which could which could cause excessive stimulations, right? And foods like coffee, tea, cola, chocolate, and in the later stages we could have nutritional supplements. Remember, in Alzheimer's disease, you want to encourage the the consumption of all grains, green leafy vegetables, non-starchy vegetables, the berries, the poultry, the fish, the nuts, the legumes. And you try to decrease the consumption of red meat, cheese, solid saturated fats, sweets and desserts, and fried foods. As for the medications, of course, we start with the first one. We have the acetylcholinesterase inhibitors, and this one are normally abbreviated by Dr. G. This is D for donepezil hydrochloride, R is for the rivastigmine, and G is for the galantamine hydrobromide. All these drugs prevent the breakdown of acetylcholine. So they have side effects like GI upset, where the patient could present with nausea, vomiting, and diarrhea. So you have to advise the patient to take this drug with food. We also have other side effects like muscle spasms, bradycardia, and for bradycardia, we could have low BP, low cardiac output, so there is an increased risk for fall. So the nurse has to pay attention and advise the patient accordingly in that case. The second category of drugs is the NMDA receptor antagonist. As you remember, we had said that glutamate also has a role in this disease, all right? So the drug here we have the memantine hydrochloride, and this is just to help preserve memory, especially in moderate to severe Alzheimer's disease. So this drug works by calming down the excitatory effects of glutamate. It has some side effects like headache, dizziness, and constipation. And this drug, it can be used in combination with these cholinesterase inhibitors. We have also a new drug by the name aducanumab, and this drug is a monoclonal antibody. It's given IV as an IV infusion around every 4 weeks in the early stages of Alzheimer's disease with the aim to reduce the beta amyloid plaques. So you have to do an amyloid PET scan or the spinal tap to confirm the presence of beta amyloid plaques before you give this drug. This drug is also associated with some side effects like brain bleeding or swelling, so we need brain scans to monitor the brain. We also have other drugs that can be used, especially in severe stages, like the selective serotonin reuptake inhibitors, such as citalopram, hydrobromide, for depression, agitation, and paranoia. We also have the suvorexant, which is an orexin receptor antagonist, and this is used in places where the patient is having sleep disorders. We can also use antipsychotics such as risperidone and olanzapine, and also other anticonvulsants like carbamazepine and valproic acid, and this is for severe aggressive agitation. We only need to know that when used in older patients with dementia related to psychosis and they are being treated with antipsychotics, they are at increased risk for dying, right? So let's look at some of the nursing interventions that you need to carry out in this particular patient with Alzheimer's disease. You need to determine the patient's level of cognitive and behavioral impairment. You have to establish a workable method by which the patient can communicate needs and also their desires. And you also use soft tone and a slow and a calm manner when speaking to the patient to prevent overstimulation and agitation. You also need to allow the patient sufficient time to answer questions to reduce anxiety and institute safety measures to prevent the patient from injury. Ensure there is adequate lighting and remove unnecessary furniture and equipment to minimize the risk of falls. You also have to provide frequent rest periods and minimal disturbances during sleep hours, and also provide an exercise and activity program based on the patient's ability and degree of restlessness and agitation. You have to offer frequent toileting, especially for those who are in severe state, and they provide assistive devices to the bathroom such as shower chairs and tap breaks. Offer assistance with self-care activities such as hygiene and dressing. This is for the severe cases with self-care deficit. And encourage the patient to perform appropriate activities to foster feelings of control, independence, and provide guided supervision during activities. Provide positive reinforcement for both large and small tasks that have been accomplished. You have to give prescribed medications as indicated. Be it the cholesterase inhibitors, the NMDA antagonists, which are our main drugs. And you have to keep in mind that there's no specific drug therapy available to stop this disease. We only treat to improve the symptoms. Ensure that the patient has swallowed the medication, because some of them they don't, and you provide appropriate finger foods and fluids that patient can consume easily and quickly, and avoid caffeine containing foods to prevent overstimulation. You have to provide familiar objects to help with orientations and behavior control and assist in modifying patient's environment to prevent injury. Also, you have to know that there is normally caregiver burnout. So you also need to monitor for abuse. In case of any, you have to report to the authorities. Frequently remind the patient of the day and hour just to help with reorientation, and place familiar objects in the patient's reach and view. You have to be consistent and you give simple step-by-step instruction and offer support and guidance to patients and caregivers. You have to be alert for a possible sundown and catastrophic reactions. And some of the triggers of the sundown feelings in Alzheimer's disease patients is exhaustion. We have sickness, maybe exposure to new medication, and low exposure to sunlight. So how you reduce a sundowner is that you ensure there is a low noise, calm, relaxing environment that is stress-free. You don't give caffeine at night to avoid overstimulation, and you keep routine schedules for the patients to avoid upset. You also need to encourage some exercise and maximum rest, and avoid long naps. Reassure the patient in case they are having hallucination, right? And you try and remove some of these objects, like the refractory objects, the mirror, which could exacerbate this condition of hallucinating, right? Okay, guys, so that marks the end of our presentation on Alzheimer's disease. We have looked at the pathophysiology, we've looked at the clinical presentation, and lastly, treatment. Kindly go through the description section to find quizzes on the 4 sections. Thank you so much.